Welcome to CE Conversations, a clinical podcast presented by creative educational concepts designed to improve clinician performance and optimize patient outcomes. This session, Overcoming Pediatric Iron Deficiency Anemia with IV Iron, Interprofessional Approaches to Integrating New Data Using Novel Agents and Optimizing Care, is accredited for 1 hour of ACCME, ANCC, and ACPE credit, and is supported by an independent educational grant from American Regent. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation at the conclusion of the podcast. And with that, we'll turn it over to our expert faculty.
So for the first half of the talk, we're going to talk a little bit about the epidemiology, pathophysiology, and iron metabolism, as well as the overall impact of pediatric iron deficiency anemia. Iron deficiency is the most common cause of anemia worldwide. It's the most prevalent micronutrient deficiency, and globally, it affects about 42% of children under the age of 5. In the United States, the prevalence is lower, but it still remains high, with ID and IDA, so iron deficiency with and without anemia, affecting anywhere from 2 to 6% of infants and young children. Here are the definitions of anemia by hemoglobin level as stratified by age and sex. So you can see just as an overview that in healthy children, in the young children, we really are aiming for a hemoglobin of over 11. As the children age, the normal hemoglobin range increases. And then for definitions of mild, moderate, and severe anemia, you can see these range from about a gram to a few grams to severe cases less than 7 to 8 grams per deciliter. Looking at homeostatic mechanisms of iron absorption, what we know is that in a healthy individual, you really only need to absorb about 1 or 2 milligrams of iron each day to balance with the regular losses, the physiologic losses that occur. So this is in a normal iron balanced state when you have sufficient iron in your body. And that's because we have a large amount of iron in the hemoglobin in our red blood cells. And then we have iron stored within the muscle, within the liver, within the spleen, particularly in the reticuloendothelial macrophages. So when these red blood cells become old and reach the end of their life cycle, the iron that's within that hemoglobin is taken up by macrophages and then re-delivered to the bone marrow to make new red blood cells. And this is a very efficient recycling system. If you become a little iron deficient, your body will pull from the liver, from the spleen, from other tissues that store iron. And that will all be transferred by transferrin in the plasma, which only has about 3 to 4 milligrams of iron. A very, very small percentage of iron is actually found within the plasma. Everything else is being used. So how is iron absorbed when we do need it? Well, ingested dietary iron is typically in the heme or ferric form, the +3 form. And when iron arrives in the stomach, the acid will convert it to the ferrous form, the +2 form. And it is this form here that crosses over DMT1, divalent metal transporter 1, where it enters the enterocyte, usually in the duodenum. That's the most common site for iron absorption. And if your body needs that iron, then the iron will cross over ferroportin, and then it'll be bound by transferrin and then delivered to the tissues. Iron metabolism also occurs through the other storage sites. So I mentioned to you before that iron is often in the reticuloendothelial macrophages. So here, this is an image of the spleen. So the macrophages there will have ferritin stored in it. And if your body needs some of that iron, it'll release the ferritin, the iron across, again, ferroportin to be delivered by the transferrin to the other tissues that need it. And this entire process is regulated by a hormone called hepcidin, which acts both on the duodenum itself and the macrophages right at the site of ferroportin. So how does this work? Well, if you've had a big iron load or you're under any kind of inflammation or had tissue injury, those are all things that increase the production of hepcidin. So hepcidin is a hormone produced in the liver, and hepcidin will increase in any of those states that I mentioned: inflammation, chronic disease, a big iron load, and it will actually block iron from being absorbed or recycled. The thought here is that in the past, iron used to be something that fed parasites. And so the immune response is to block iron from being available to parasites and other siderophilic bacteria. So hepcidin is thought to have this immune function, but in states of inflammation or other iron loading, it will also be increased and suppress iron from being absorbed or released. When hepcidin is elevated for this reason, dietary iron, particularly oral iron, any oral iron supplementation or other dietary iron will not be adequately absorbed. So over time, in individuals who have chronic inflammation and chronically elevated hepcidin, they will develop what's something called functional iron deficiency, or FIDA. This is in contrast to absolute iron deficiency. So absolute iron deficiency means your absolute stores are very low. You just are not getting enough iron in, which classically happens in young children who are drinking too much milk and not getting enough iron in their body. This is just another illustration showing hepcidin's impact on iron availability. So anything that leads to increased hepcidin will block ferroportin from the enterocyte. So you block intestinal iron absorption. It will block iron from being released from the macrophages. And that results in less iron availability, which results over time in iron deficiency anemia or anemia of inflammation, otherwise known as functional iron deficiency anemia. So these next two slides will contrast absolute and functional. As I mentioned before, with absolute iron deficiency anemia, you do not have enough supply to make the red blood cells. So you might have less intake of iron. What you do have gets absorbed and bound to transferrin, but that storage pool, the iron in the liver or the spleen, is very low. And you have a decreased supply, so you're just making less red blood cells. In contrast with functional iron deficiency, you have enough iron in your storage pool, and you might be getting iron intake in, but for some reason your hepcidin production is elevated, and that blocks the absorption, it blocks the iron release, and you have less supply again to make the red blood cells. So over time, with chronic inflammation, again, you will get a microcytic anemia progressively. So now looking at the different etiologies of IDA in pediatrics, this is kind of a summary, an overview of the most common causes. In the young children, nutritional iron deficiency is by far the common cause. It's a low iron diet, often in children who are breastfed exclusively without any iron supplementation or table foods initiated, or it's toddlers who have switched over to taking cow milk and are drinking cow milk as their primary source of nutrition, not getting enough table foods in. The next common group that's affected are adolescent girls, and this is primarily due to menstrual blood loss, which outweighs the balance in a net negative way. And this is specifically true in adolescents who have abnormal or heavy menstrual bleeding. Periods of rapid growth will increase the risk of iron deficiency. So in rapid growth, you actually need more iron than someone who is finished growing. This is also why pregnant women require more iron, because they're supporting both themselves, the increased blood volume, and the support for the fetus. Any kind of occult blood loss from the GI tract or underlying GI disorder can cause poor absorption or ongoing GI blood losses, which are two mechanisms that can cause it. Many GI disorders also have underlying inflammation, like inflammatory bowel disease. And this is also true in patients with heart failure or chronic kidney disease who have kind of multifactorial reasons for becoming anemic. And then very rarely there is a genetic condition called iron refractory iron deficiency anemia, or IRIDA. This is extremely rare, but in those patients, they have excessive hepcidin production and cannot absorb or utilize iron very well. This is just, again, looking in a table format, some of the different etiologies broken down a little bit more. So in the newborn period, if you have a mother of an infant who was iron deficient during pregnancy, they couldn't deliver enough iron to that during the third trimester of pregnancy. Any infants that had IUGR are at higher risk for iron deficiency. And then any newborn or infant that has to have some type of intestinal surgery are going to be at higher risk of iron deficiency. In those infants, as I mentioned, exclusive breastfeeding without iron supplementation places them at risk. Or if they've had early introduction of cow milk, so prior to 1 year of age, if they stop taking iron fortified formula and are taking other forms of milk that don't have enough iron in them, they're at risk. In the toddler group, 1 to 4-year-olds, again, inadequate intake. So they're just really picky. They want to drink milk. They like it. They like holding onto that bottle. That places them at high risk. And in the school-age children, this is really rare. You really want to think about GI disorders, disorders like celiac or kind of undiagnosed blood loss. And then in adolescents who have achieved menarche, certainly heavy menses can contribute. Looking at other etiologies that cause chronic inflammation, blood loss, these include inflammatory bowel disease. So this is kind of multifactorial, many different risk factors for IDA, poor absorption, inflammation, blood loss. There's many other GI disorders can similarly affect the GI tract and affect iron absorption. Individuals with chronic kidney disease may have low erythropoietin production and have other risk factors for blood loss, increased hepcidin. And then children with heart failure, we've learned more and more that iron deficiency can have a lot of effects on the heart function itself and is important to assess in those cardiac patients. Any children or adults who have gastritis or reflux that require antacids are also going to be at risk. So they have ongoing inflammation, potentially some occult GI blood loss, but then when they're on that anti-reflux medication, less conversion of that ferric iron to ferrous iron. So what are the consequences of iron deficiency? Well, there are cellular effects and then more patient symptom presentations. At the cellular level, there are impaired immune functions. So there's been studies that show that in infants and young children, they have a poor immune response to vaccines. If they're iron deficient, they just don't mount the same antibody production. There are cell cycle irregularities. There's neurohormonal disruption, deficiency of iron in the myoglobin. So this is what particularly affects children with heart failure. Those cardiac myocytes need a lot of iron in there to function properly. And if you're iron deficient, you're going to have less myoglobin or poorer myoglobin function, diminished mitochondrial capacity, and then even impaired DNA replication and repair. So what does this mean? It means iron deficiency has important neurologic impacts on infants and children. So iron is required for the myelinization of neurons and neurogenesis and neuronal differentiation, which is really crucial during those first few years of life. Iron is a cofactor for enzymes that synthesize neurotransmitters, such as dopamine. There are psychomotor and developmental consequences associated with IDA. So you can have effects on cognition, motor and attention and memory deficits, decreased school performance. This has been seen in adolescent girls that have been tested, and lower levels of physical activity seen in adolescents and even adult workers. There are concerns for the impact on attention deficit and hyperactivity, and then sleep and neurologic conditions, including restless leg syndrome. So a lot of global impacts of iron deficiency. So for all of these reasons, screening for iron deficiency is particularly important. And the American Academy of Pediatrics had a 2010 report that has screening recommendations that all children at 12 months of age should be screened for anemia to rule out iron deficiency. A new report is in development, and this will continue to recommend the initial screening at 9 to 12 months of age. It will likely recommend repeat screening for high-risk children, those who have been fortified with iron through formula during the first year of life and then switch over to drinking cow milk are at higher risk at 15 to 18 months. And the newer recommendations will likely include screening for adolescent girls as well, the other high-risk group in pediatrics. So how do we diagnose iron deficiency? This is a table that compares absolute iron deficiency, just iron deficiency itself, with the progression to anemia. So iron deficiency will occur before the anemia comes along. And you'll see this in lower ferritin levels, lower transferrin saturation levels, but you might have a normal hemoglobin and MCV. Over time, however, if that child doesn't get enough iron in the diet, or that adolescent girl continues to have heavy menstrual bleeding, that iron supply that has been feeding those red blood cells will eventually run out, and then the anemia develops. So you get more severe, lower levels of ferritin, lower transferrin saturation. You get elevation in testing labs like the serum transferrin receptor or soluble transferrin receptor. And then eventually you'll see impact on the reticulocyte hemoglobin or the hemoglobin or MCV itself, which is in contrast to patients with iron overload who have normal CBCs and elevated ferritin and elevated transferrin saturations. I really love this figure. It kind of shows the different types of iron status with and without inflammation. So here we're looking at the ferritin, which is a marker of storage iron, the transferrin saturation, which is really a marker of circulating or transport iron, how iron is delivered. And then you have the hemoglobin, which is the iron in the red blood cell. So in a normal state, all of these things will be full. All the tanks are full. You have good storage iron, your transport iron is full, delivering everything that it needs. And then the iron within the red blood cells is fully replenished. In iron depletion, you start seeing effects on the storage iron because the body wants to maintain red cell production. So it's going to pull from the liver and the spleen and other sites before affecting that hemoglobin. However, over time, that ferritin, the storage iron, will be depleted. And then you're going to start seeing impacts on the transport iron. And then eventually you're going to see that the hemoglobin is affected as well. In contrast, when you look at inflammation, you have enough iron stored. So your ferritin may be normal or even elevated, but it cannot be delivered out into transport because, again, hepcidin is blocking the iron from being released. So that transport iron is going to be low. The TSAT, the transferrin saturation, will be low despite having a normal ferritin. And then your hemoglobin will still be impacted. So this is like one of those pre-test questions we were looking at. Normal ferritin, low transferrin saturation, low hemoglobin. This is most likely functional iron deficiency. So what are some of the symptoms of IDA in children? You probably know this, but the symptoms can be very dependent on the severity of anemia. It usually has a gradual onset, but many children can be asymptomatic because of that, and they can tolerate much lower levels compared to us, the adults. Clinical signs and symptoms that are common include irritability, so sleeping or being a little bit more lazy. Some of the parents will say pica or the craving of non-food items, so chewing on a lot of ice, paper, dirt, rocks, unusual items. Fatigue, pallor. Severe symptoms, particularly in older children and adolescents, can include dyspnea, shortness of breath, especially if you have an athlete who's a runner or basketball player, palpitations, tachycardia, and in severe cases, syncope. Hopefully you won't have patients that progress to this extent, but we certainly see it at our hospital, patients presenting with hemodynamic instability sometimes if they have an acute hemorrhage. We have seen patients, even young children, with heart failure, stroke, and cerebral sinus venous thrombosis. So these are really serious consequences we want to avoid. So for the second half of the talk, we're going to really focus now on IDA management and look through the IV iron products that are available. As you know, there are really two options for replacing iron in individuals. You have oral iron supplementation versus intravenous iron therapy. Hopefully, many of you are very familiar with oral iron therapy. They can be effective, particularly in those patients with absolute iron deficiency, no inflammation going on. They take the oral iron, it's absorbed, nothing's blocking it. It is less effective in functional iron deficiency anemia for the reasons we said, right? That hepcidin is going to block oral iron from being absorbed. And of course, there are adverse effects of oral iron therapy, such as constipation or abdominal pain. It doesn't uniformly affect patients. There are many patients that do fine with oral iron therapy, but you know many that are very sensitive, and it affects them and they cannot tolerate it. Finally, oral iron does require adherence for several months. Usually 3 to 6 month course is what I tell most of my families. Intravenous iron therapy, so this can be considered first line in the setting of chronic inflammatory disease, like the ones we've mentioned, IBD, heart failure, chronic kidney disease, and in those patients who have ongoing bleeding, if oral iron is ineffective or intolerable, and in situations of severe anemia. So our emergency center has been using more IV iron therapy in patients who are stable enough to not need a blood transfusion, but you're really worried that they're kind of on that cusp and not sure if they're going to be able to take oral iron. We consider IV iron therapy in that setting. It does avoid the challenge of adherence. You bypass the intestinal mucosal barrier, so that means you're not getting those GI side effects with IV iron. And because you can deliver a large quantity of iron, particularly in the newer drugs we'll talk about, you have a faster hemoglobin response. So let's look at the mechanism and how IV iron can overcome some of the blocks that we see with chronic disease. So IV iron essentially can quickly saturate the serum transferrin, the transferrin that's delivering the iron, and that prompts ferroportin, that delivery system, the transmembrane, to become overexpressed and allow a lot of that iron to be utilized. Here on the top left corner of the screen, you'll see this is a normal individual that has iron stored in the macrophage. You have a normal ferroportin, and that iron is transported out to be bound by transferrin. In chronic disease, so the lower left-hand corner here, you have hepcidin that's blocking ferroportin, so you can still get some iron out, but at lesser extent than someone who is not inflamed. Going up to the top right corner, in someone with chronic disease and you're giving oral iron to, that's not really going to have a big impact because it can't overcome the hepcidin barrier, just getting a small amount of iron a day. So it's not really making a big change. But when you give IV iron, you're really loading up, you're saturating the system, and this causes overexpression of ferroportin, which then allows more iron to be released. So you get a little bit of a compensatory mechanism. You can overcome that hepcidin block. So understanding that, let's dive into the IV iron products themselves. So there are 6 IV iron products that are now approved for adults in the United States. So we'll have 2 slides on these. These are the first 3 we'll talk about. So iron dextran, ferromoxetol, and sodium ferric gluconate. Dextran and ferric gluconate, we'll talk in a little more detail. These are approved in children. And then the other 3 drugs are iron sucrose, ferric carboxymaltose, and ferric deoxymaltose. So again, 2 of the 3 here, iron sucrose and ferric carboxymaltose, are both approved in children. Ferric deoxymaltose was just approved in adults in this last year, and I haven't seen any pediatric data on that drug yet. So we're going to focus on just the 4 IV iron preparations for which there is pediatric labeled indication. Iron dextran is the oldest drug. It was originally approved by the FDA in 1974. In its original form, there was a high molecular weight iron dextran form. That is not the one that's available now. It was converted to a low molecular weight iron dextran form. This is much safer than the other ones. So you have in the back of your mind, if you have iron dextran with a lot of adverse effects, that was probably the older form that had higher rates of anaphylaxis, not this newer form. This is the least expensive IV iron formulation because it's the oldest. You can use total dose infusions in practice, but these are off-label. So the label dosing is up to 100 milligrams per infusion, but off-label can be given up to 1,000 milligrams. It is required that you give a test dose prior to a therapeutic dose. This is one of the studies. It was a retrospective case series in pediatrics looking at low molecular weight iron dextran published last year in Pediatric Blood and Cancer. And it was really just focusing on efficacy and frequency and severity of infusion-related adverse events. So this was a single center study, but there was 190 patients treated with over 250 infusions. Most of the patients received a single infusion dose, probably the total dose infusion or off-label indication or off-label dosing, excuse me. There was a wide variety of patients that were treated, and most of them received around 650 milligrams of iron with a good increase in hemoglobin, and about 4.7% had mild limited adverse reactions. Overall, they thought it was a good, safe medication that could be used at off-label dosing. The next drug we're going to talk about is ferric gluconate. So this was approved by the FDA in 1999. And the goal there was to develop something that might be a little bit safer to iron dextran. The limitations for ferric gluconate, it's really only studied in the pediatric population for patients with hemodialysis. So you're really limited to how many doses or how much dose you can give per infusion. And you can't really overcome that with an off-label large dose with ferric gluconate. Originally you needed a test dose, but later found to be unnecessary, so you don't have to avoid that. This was a study published in Pediatric Nephrology in 2005, looking at 2 different regimens of ferric gluconate, 1.5 mg per kg versus 3 mg per kg. So these are both pretty low dose. I think it's a good drug. I think it's good for patients who are on hemodialysis, who are already coming in regularly to clinic. They can kind of get a boost of IV iron that's safe and effective along with their other infusions. The next drug we'll talk about is iron sucrose. So this is another drug that's pretty similar to gluconate, but you can dose it a little bit higher. They're often kind of used interchangeably at many centers. It was approved by the FDA shortly after ferric gluconate. So iron sucrose was approved in 2000. Again, FDA approved for use in chronic kidney disease. The single dose sizes, again, are pretty limited compared to iron dextran. So there is a maximum dose you can give. If you go beyond that, you have a lot of free iron release, which can cause some hypersensitivity reactions. This drug has been very popular for many years. This was a case series from 11 years ago from a group at UT Southwestern that were, again, looking at their retrospective data on patients with a wide variety of indications. So they were dietary, iron deficiency anemia, GI blood loss, and other causes. In these patients, they received a typical dose of 100 milligrams. You can give up to 300 milligrams in the older patients. It was effective at raising the hemoglobin in most patients. However, most of them needed at least 3 doses. And in your adolescent patients, sometimes you need up to 5 to 6 doses to give kind of a fully replenished treatment course of IV iron therapy. Of these patients, there were 500 doses given total and only 6 adverse events. So it is very safe, which is really appealing. It's pretty affordable and it is covered by most insurance programs. A few years ago, the group at Cincinnati wanted to look at IV iron safety and stigma, really trying to overcome some of the barriers to use of IV iron therapy because of the historic rates of high reactions. This group was looking at all the IV iron doses given at their center over about a 7-year period. And there they had given over 1,000 doses administered to 194 patients. Many of the patients had required multiple doses. They only used pre-medications in about 10%, and there were no severe infusion-associated reactions occurring, at least in their pediatric retrospective review. So this is looking only at the older products. I think iron sucrose and iron dextran were the primary drugs used in this study, but showing that even in those older generation products, quite safe and effective. So now we're really going to focus on the next generation of IV iron products. So these are kind of the 3rd generation, and these include ferric oxetol, ferric carboxymaltose, and ferric gersomaltose. What sets these newer products apart is that there's a newer iron carbohydrate complex that basically is able to envelop and securely give a large amount of iron without a lot of iron free radical generation. So for the older products, all of them, if you notice, have like a carbohydrate in the name. You have dextran, gluconate, and sucrose. And similar with these, there's a carbohydrate shell that goes around the iron core. And the dose that you can give is really dependent on being able to ensure that the iron doesn't become have free iron release, that the body can bind to that iron in a safe and effective way. And these new products allow you to give a much bigger dose safely without preventing that free iron release from occurring too rapidly. So these are the different characteristics of these carbohydrate shells, which make it a much safer way to deliver high doses of iron. One big thing that I hear a lot about IV iron therapy is that it's not safe. There's high rates of anaphylaxis. And in the past, that used to be true. So there was, in the high molecular weight iron dextran containing products kind of a long time ago, up to 3% had severe reactions, with life-threatening anaphylaxis occurring in 0.6%. But these newer formulations do not have the same risk. So I want you to wipe that from your mind, and I want you to keep in mind that the severe reactions with IV iron are now estimated to occur in less than 1 per 200,000 doses administered. So what that means for these newer products is that anaphylaxis or anaphylactoid reactions occur in 0.1% to 0.3% of the doses given. So this is much, much safer than in the past. So we'll talk now of the 3 newer products. Ferric carboxymaltose is the only one that has an FDA labeled indication in children. It was originally approved for use in adults by the FDA in 2013, so almost 10 years ago. Again, it's an iron core that's stabilized by a carboxymaltose shell. And the stability of this complex is what allows you to get large amounts of iron without it being released into the serum. So when I was at UT Southwestern in Dallas a few years ago, we learned about carboxymaltose. We saw a lot of the European data and some of the adult data in the US and found it really compelling. And so we're able to add it onto our formulary, even though it was off-label to use in pediatrics. And we treated it based on a protocol that we modified from the adult labeled dosing. So this is an off-label protocol that we had used at the time. And we treated 72 children from 9 months to 18 years of age. And we monitored the efficacy and, of course, for adverse events. We administered 116 infusions to these patients. We saw really nice changes in the hemoglobin from 9 to 12 over the 4 to 12 week post treatment course. And there were minor transient complications only in 7 infusions. So some of these included tingling at the IV site, some localized urticaria. But overall, we found that ferric carboxymaltose, given as a short infusion at our center at the time, we gave it over 15 minutes without a test dose, was very safe and effective in this diverse patient population. There was another study published just this year looking from Seattle Children's that were comparing children with intestinal failure. So these are children that have intestinal surgery, might have short gut syndrome or other effects on the bowel. And they were treated either with iron sucrose to ferric carboxymaltose and looking at changes. And for the iron sucrose cohort, they were being treated at 1.5 mg per kg twice weekly, whereas in the ferric carboxy cohort, they could get 15 milligrams. So the dosing there, you can see you can give 10 times the amount of iron with a single infusion of ferric carboxymaltose. So that's a big deal. I mean, 10 infusions in one. Compare that as far as impact on school attendance, days from work off for the family. It makes a big dramatic difference, especially when the safety is comparable. Between these two groups, they saw no big differences in the hematologic parameters, but again, looking at the number of infusions for the iron sucrose group, they were getting about 15 infusions compared to just 2 in the ferric carboxymaltose group. So really big difference there. Both of them were found to be safe and effective, but the less dosing with carboxymaltose can make it really appealing. This was another study looking at children with inflammatory bowel disease. Again, we're able to get a single dose of ferric carboxymaltose, 15 mg per kg. And just with a single dose, a lot of them had resolution of anemia. Several had to have a couple doses. That's not uncommon depending on the degree of their iron deficiency anemia. This is just a schema showing you the clinical trial that was conducted in pediatrics, which is wonderful because in peds, a lot of times we don't benefit from a full clinical trial in our patients. But this is a phase 3 study that was conducted where they looked at change in hemoglobin from baseline to day 35, change in ferritin and transferrin saturation. They enrolled 40 patients, and this paper is pending, but you can find more data at clinicaltrials.gov. I will mention that the adverse events, something that's also probably worth monitoring in these patients is the phosphorus levels. There can be the development of a transient hypophosphatemia. I've never had a symptomatic patient. It's a pretty low risk, but something that you can monitor for. So ferric carboxymaltose, like we mentioned, it was approved less than a year ago for children aged 1 year and older who are intolerant to oral iron or have had an unsatisfactory response. So you don't have to have chronic kidney disease to get approval for this drug. So the next question may be, how do we dose it? And IV iron dosing in pediatrics, you can look at the labeled indication on the product, or many people like to calculate the iron deficit itself. And this is based on something called the Ganzoni equation, which you can use. You can usually Google it online, but you may have a calculator within your formulary. And essentially what you're doing is trying to figure out how much iron do you need to get that hemoglobin back to normal, plus iron to fill up the storage sites, and then that's your cumulative dose. So here you have the target hemoglobin minus the actual hemoglobin by the weight, and then 15 times the weight. This is your estimate for how much iron you need for your storage sites. And that will give you your cumulative dose. Once you have that dose, you want to look and see what products you have on your formulary, and you can see how many infusions you may need to deliver to give that total dose to your patient. So we're going to go through, I'll show you some of the guidelines that exist. We won't go in detail now, but then into those, but then we'll walk through a couple cases and then we'll wrap up with our post-test. These are some of the existing guidelines that look at chronic kidney disease and looking at oral iron indications versus IV iron therapy. There's some guidelines from ISHLT for pediatric heart failure, and then several for children with inflammatory bowel disease, looking at the degree of the anemia and if they're able to tolerate oral iron or not. Here are a couple more kind of IBD or GI focused guidelines if you want to reference those in the future for any of your patients. In general, because there isn't really wide-ranging clinical practice guidelines regarding IV use in pediatrics, in general, what you can consider is that first line for patients who have chronic inflammation who will not be able to tolerate or absorb oral iron, so inflammatory bowel disease that is not in remission, chronic kidney disease in patients with hemodialysis needs who are on erythropoietin stimulating agents, ESAs is more effective with IV iron, any other active states of inflammation and concomitant iron deficiency. So think about rheumatologic patients and girls with heavy menstrual bleeding. And then it can be used as second line therapy for patients who fail to improve after oral iron therapy. Typically, you need to demonstrate a good trial of oral iron for at least 4 weeks. And then you could submit to the insurance for coverage, or if they're unable to tolerate oral iron therapy. And then you have to work with the individual providers as far as which formulations they will cover. Sometimes you have to do some extra justification and prior authorization for the newer IV iron products. Okay, so let's work through a couple patient cases. Patient case 1, NT is a 7-year-old male who was diagnosed with ulcerative colitis 1 year ago. He presents now with another disease flare. He has bloody diarrhea, abdominal pain, and fever. His GI physician is going to initiate steroids and infliximab, but his parents want to avoid as many infusions as possible, of course. Infection and colitis are ruled out as causes of his fever, and he weighs 19.5 kilos. So when he presented a year ago, his nutritional deficiencies were significant for iron deficiency, and he started on oral iron supplementation. And that has been complete. So now with the recurrence of his ulcerative colitis, his labs are significant for a functional iron deficiency. His serum ferritin is 94, his transferrin saturation is 14%, his hemoglobin is 8.8, and his reticulocyte count is 1%. So some of the things we think through with this case are, what is NT's calculated total iron deficit? Is he a candidate for IV iron replacement? And what products and dosing would be reasonable for him? So we're going to kind of synthesize everything we just went through. So we're going to look at his total iron deficit. We're going to use the Ganzoni formula here instead of just looking at the label dosing. And for him, we want to target a hemoglobin of 12, and we know he's at a hemoglobin of 8.8. So this is the difference in hemoglobin. This will give us a sense of how much iron we're going to need to get that hemoglobin to normal. We're also going to replenish his iron storage site so that he'll be completely better, and that'll be 15 times his weight. And altogether, that means he needs about 300 milligrams of iron. The next question is NT a candidate for IV iron replacement? And I would suggest that yes, he is, because he has an active inflammatory bowel disease with chronic inflammation. He has moderate to severe anemia, and he has a diagnosis of functional iron deficiency. So we don't think oral iron will be effective. He has active inflammation. So IV iron is really optimal for this patient at this point. There is an algorithm here, which we don't have time to walk through the entire thing, but for the diagnosis and management of anemia in children with IBD, this is from the Journal of Pediatric Gastroenterology and Nutrition, published a couple years ago. But in patients who have active IBD, the recommendation is to go straight to IV iron therapy. Okay, If they have IBD in remission and they have moderate to severe IDA, you also want to consider IV iron in lieu of oral iron therapy, which should really just be for patients with mild anemia or non-anemic iron deficiency. So now to the final question, which products and dosing are reasonable for this patient? And we're going to focus just on 3 of the products. You can really think of iron sucrose or ferric gluconate interchangeably here, but if you're looking at iron sucrose, the max dosing is really 5 mg per kg. In a patient of his age and size, you don't want to go over 100 milligrams per dose. That's the labeled recommendations. Knowing that he needs 300 milligrams of iron, that means 3 infusions. Iron dextran, again, the max label dose is 100 milligrams. He could get this over a course of 3 different days. He would need a test dose. You can, on an off-label way, use 300 milligrams, so that is another consideration. And then we have the newer product, ferric carboxymaltose, 15 mg per kg, which equals 300 milligrams, which allows you to give 1 dose, and this is using an FDA-labeled dosing. So all 3 of these are potential options. It depends what's on your formulary and just kind of how you think it through and what you want to get approval for with the insurance and discuss with the family. Patient case 2, and then we'll go to our post-test. PW is a 15-year-old female with a medical history significant for abnormal uterine bleeding. So her cycles last 8 to 10 days beyond the typical 7-day cutoff. She was previously diagnosed with iron deficiency anemia and started on ferrous sulfate, 325 or 1 tablet daily, along with vitamin C. At her follow-up visit, she has continued fatigue, but now she's nauseous with her iron pills. And after 12 weeks, so a good 3-month course, her ferritin remains low at 8, her transferrin saturation is 18%, her hemoglobin is 10.1, and MCV is 77. So we know she has a microcytic anemia that's persisted despite 12 weeks of therapy. Her ferritin is still low, so my cutoff is at least a 15. I usually aim for 20 for these patients. The questions here are, is she a candidate for IV iron therapy, and what formulations would be reasonable? I would definitely recommend IV iron therapy. She's had a reasonable 12-week course. You usually need a minimum of 4 weeks. And in most of my patients, I can predict after a month whether they'll improve or not. But she's failed oral iron therapy. She can't tolerate it anymore, and this could be justified to the insurance company. So what IV iron formulations would be reasonable? Again, you can look again to the same 3 products. Iron sucrose, think of it the same as ferric gluconate. So carboxymaltose, sucrose, or dextran are all viable for the labeled indications in this patient. And really you want to think about what you want to do based on the individual patient, how you want to approach it, what you can get approval for, and what you think that patient will want to come back for. In a lot of my patients, the worst part of the process is getting an IV placed. And so less IV sticks is better for them. But whatever you can get approval for will be important. Okay, so we're going to work through the same post-test. We'll go over the answers this time, or share the answers with you all. The first question, iron deficiency anemia can cause harmful and potentially irreversible effects in pediatric patients if not effectively managed. Which of the following are possible clinical consequences of IDA in children? Okay, great. So the majority of respondents said all of the above, and I know we had a couple of late participants. You may have missed this, but this is actually, all of these things are associated with iron deficiency. So the concern for developmental delay, there's increased risk for ADHD, attention deficit disorders, and then less immune response to vaccines, as well as concern for higher risk of infections when you're iron deficient. So all of the above. Right. JL is a 13-year-old female who presents with fatigue, You order labs, which show a serum ferritin of 95, a transferrin saturation of 14%, and a hemoglobin of 8.6. You diagnose JL with which one of the following? Okay, so the majority of you all who answered got it correct. So it is actually functional iron deficiency anemia. You can see that her ferritin is normal, but her transferrin saturation is low. This indicates that she has enough supply, so she's not, doesn't have absolute iron deficiency. That's when you do not have enough iron at all in your body, your ferritin would be low. But maybe it's not accessible, and that's what's causing her anemia. So that's really a functional iron deficiency anemia. Instead of anemia without iron deficiency, which means there's something else going on. She's not iron deficient. In the setting of pediatric inflammatory disease, such as IBD, heart failure, chronic kidney disease, or cancer, hepcidin levels are elevated. How does elevated hepcidin impact iron supplementation strategies in these patients? Okay, so the correct answer is B. IV iron should be used preferentially. So remember, when hepcidin is elevated, oral iron cannot be adequately absorbed. So you really don't want to use oral iron in patients with active inflammation because it's basically going to just stay in the GI tract and cause GI side effects without much of the benefit. You usually can't overcome this with higher doses of oral iron, and the same is true for the oral ferric formulations. They're not really going to overcome that hepcidin block. So really, with high hepcidin, you want to go with IV iron. Okay, the following IV iron products are FDA approved for use in pediatric patients, except, which is the exception? Okay, good. The majority got this. So the only one that's not approved in children of this list is ferric deoxymaltose. That's a new one, just approved within the last year. But carboxymaltose, iron sucrose, and iron dextrin are all approved in pediatrics. And this is our last question, and then I'll answer any questions in the chat. Which of the following is true about IV iron safety? Okay, so correct. Severe hypersensitivity reactions are extremely rare, so less than 1 in 200,000. Just to review for the other answers, for B, it's actually the stronger the carbohydrate shell, the slower the iron release. So you kind of hold on to that iron and protect it better. That's why those products can give higher doses of iron. For C, molecular weight does impact the safety of IV iron products. So iron dextran, there was a high molecular weight form that was more anaphylactic, not anymore. And then the rate of anaphylaxis in anaphylactoid type reactions is now 0.1 to 0.3%, not 3%. That was an old IV iron product. So I will now answer. There is one question in the chat. Feel free to put in more if you would like. So a question that came up is, with ferric carboxymaltose receiving an expanded indication to include pediatric patients, what do you anticipate in terms of clinician uptake? Which IV iron products are used most commonly in peds currently, and how do you expect that to change? So just in the last 5 years since we added it to our formulary in Dallas, I'm in Houston now, and I liked ferric carboxymaltose based on my experience there. So it's our preferred drug here, and a number of other centers have added it. I think the main limitation, so I expect it to have more use, is to answer your question directly, but the main limitation is that the newer IV iron products are harder to get approved from private insurance companies. Their first line is usually the older products, and they usually like a justification to use one of the newer products. And that's the main limitation as far as using the newer products. So I think it's just the uptake will increase, and it's a lot of work to get it authorized. But if you can get the newer products authorized, I think giving a large safe dose of iron is ideal. Okay, there was another question. Do patients get leg pain taking iron by mouth, and why? I have never had a patient tell me they get leg pain taking oral iron therapy. GI side effects are the most common, and that's just related to unabsorbed iron within the GI tract, causing some irritation, although not all patients get it. You can treat, there are patients with restless leg syndrome who respond to iron therapy. So I don't know if there was some association there. And then I'll ask, but no, oral iron shouldn't cause any leg pain. And then my last question, since we're at time, is hypophosphatemia a concern with patients needing ongoing IV iron with ferric carboxymaltose? Could it affect bone health? This is an excellent question that's not known. So hypophosphatemia can occur in between, the estimates that I've seen are between 13 to 18% of pediatric patients. It usually occurs about 10 to 14 days after the infusion, if it's going to occur, and then it resolves on its own. As far as repeated doses, I don't know. If you have someone with long-term recurrent use of IV iron therapy, then I would definitely monitor the phosphorus and or potentially consider an alternate product. If you're doing it for a single treatment course, which is what most pediatric patients need, I think you should be fine.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and, most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.